friends from Peru. I am very sorry I cannot be with you in person, but I hope that this recording will help you understand everything you need to know on idiopathic intracranial hypertension. I am Valerie Biousse, neuro-ophthalmologist in Atlanta, in Georgia, in the US. I really do hope I will be able to come back in person to Peru soon. I was there last year and had a wonderful time. So, as you know, IIH has become a really common problem that most of us, regardless whether neurologist, ophthalmologist, or neuro-ophthalmologist, see pretty much every day nowadays. I do not have any relevant disclosure. And I want to start by presenting two cases to you, just because they are a little bit disturbing. This one is a 25-year-old woman who has a routine eye examination for glasses. She's obese, she has no symptoms, and she is found to have bilateral optic disc edema, which prompts an urgent evaluation. Her blood pressure is normal, neurologic examination is normal, her afferent visual function is normal. And as you can see on the right here, she has bilateral optic disc edema with normal visual fields, just enlarged blind spots in both eyes, consistent with the most likely diagnosis of papilledema. And I want to highlight that when we talk about disc edema, it's any cause of optic nerve head edema. But when we talk about papilledema in English, it means bilateral most often, but could be unilateral or very asymmetric optic disc swelling from raised intracranial pressure. So papilledema specifically refers to raised intracranial pressure. And because you're very concerned about causes of intracranial hypertension that could be major problems, such as, for example, a brain tumor or venous sinus thrombosis, you want to obtain brain imaging urgently. She had an MRI of the brain without and with contrast, as well as an MRV of the head, looking for venous sinus thrombosis. And this MRI was what we call normal in the way that it rolls out an intracranial process. It's not an intracranial mass. It's not obstructive hydrocephalus. It's not venous sinus thrombosis. But the reality is that these MRIs performed for patients with papilledema very often are not normal and show non-specific signs that suggest intracranial hypertension. So, for example, empty cella or partially empty cella, dilation of the optic nerve sheath in the orbit, posterior scleral flattening, especially in patients who do have severe papilledema. And then when you do an MRV, you will not see venous sinus thrombosis, but you very often will see distal bilateral transverse venous sinus stenosis. So these signs tell you that the patient has had chronic intracranial hypertension for a little while. The next step is to perform a lumbar puncture, which will be done in a way that will allow for measuring the opening pressure, which is high here, 39 centimeters of water, and the CSF contents are normal. So the patient is rightfully diagnosed with idiopathic intracranial hypertension. It's a mild form. She doesn't have any headache. She has mild papilledema. Her visual function is normal. And she started on acetazolamide, 500 milligrams twice a day. And she's sent to a primary care doctor to seek some help to lose weight, which is the definite treatment of IIH, as you know. She will develop a post-lumbar puncture headache related to low CSF pressure headache, which is common. But she eventually gets better, and 3 weeks later, when she's seen in follow-up, she has no headache. She dislikes the acetazolamide, which is always the case because patients complain of side effects. She has lost 10 pounds since the lumbar puncture, probably because the acetazolamide made her sick. The papilledema is improved, as you can see here. 3 weeks later, it is better than initially. The Humphrey visual field remain normal, which is good. And eventually, on acetazolamide and further weight loss, the papilledema will resolve within just a few months. Vision will remain normal. The acetazolamide is discontinued, and she subsequently does very well. But then the following day, you have this one walk in your clinic, 19-year-old woman with headaches and rapidly progressive vision loss. She's also obese, and she tells you that she was completely fine until about 2 weeks prior, at which time she developed severe headaches, rapidly worsening vision loss in both eyes, and binocular horizontal diplopia. When you see her, her blood pressure is normal, her visual acuity is decreased, and she has decreased color vision in both eyes and a right relative afferent pupillary defect, telling you that there is bilateral optic neuropathy, asymmetric, worse in the right eye than in the left eye. Remember, she had diplopia, and you see that she is isotropic in primary position. It gets worse when she looks to the right because she has a abduction deficit in the right eye, and the neurologic examination is otherwise normal. So it's one of those situations where looking at the back of the eye is essential, and you see here very severe bilateral optic disc edema with hemorrhages, dilated veins, exudates, and the visual fields, unfortunately, are very constricted in both eyes. This presentation is highly suggestive of either very severe bilateral papilledema from intracranial hypertension. Remember, she had headaches. And if this is the case, you are really worried about an intracranial process such as a brain tumor, venous sinus thrombosis, a meningitis. But because the visual acuity is decreased, you have a relative afferent pupillary defect. It could also be bilateral optic neuritis. And this is why your MRI must involve the brain, but must also involve the orbit, be performed with contrast because you want to roll out an intracranial process, and you want to roll out optic nerve enhancement, which would suggest an inflammatory optic neuritis or infiltrative optic neuropathy, something that would not be papilledema from raised ICP. Turns out it's normal. She only has signs of intracranial hypertension, but no intracranial process, no optic nerve enhancement. The brain MRV does not show venous sinus thrombosis, and as expected, she has bilateral transverse venous sinus thrombosis, stenosis. She has a lumbar puncture, which shows very high CSF opening pressure and normal CSF content. She's not anemic. She has no known sleep apnea. She's on no medication, and I showed you already the blood pressure that was normal. So you have no choice here but make the diagnosis of idiopathic intracranial hypertension. And the only difference with the previous patient is that this one is what we call fulminant, very acute onset, very rapid worsening, and very altered visual function. So she's admitted to the hospital. She has a dramatic immediate improvement of headache and diplopia after the lumbar puncture. She's also given acetazolamide, but we know she's going to need a surgical procedure or she's not going to do well. We are immediately consulting our neurosurgery colleagues, and we ask them to place a lumbar drain, which is basically a drain that looks like a lumbar puncture that never goes away. And the lumbar drain is something neurosurgeons can do very easily in the ICU to temporize the situation. This patient got much better after a single lumbar puncture, but then the symptoms recurred very quickly afterwards. The lumbar drain is really going to quiet everything, make the patient feel better by relieving the headaches, and also stop the optic disc edema and optic nerve damage from worsening. And that allows you to discuss with neurosurgery whether they would be willing to do a cerebrospinal fluid shunting procedure. We also discussed with our oculoplastics to ask whether they would consider an optic nerve sheath fenestration on the worst eye. In the meantime, the headaches and diplopia recur, the lumbar drain is placed, the ventriculoperitoneal shunt is placed the next day. She does improve a lot. As you can see, the visual acuity improves. However, she will develop secondary optic atrophy with very constricted visual fields, but at least her central visual acuity improved. And this is her fundus and visual fields about 3 months later. So this is a case of fulminant IIH. And what I really want you to think about is, these are the same diseases. They are both idiopathic intracranial hypertension patient, very benign in one, very severe in the other. Is this really the same disease? We do not know. You all know that what to do when you have a patient who presents with bilateral disc edema in the setting of headache most often, which will make you suggest intracranial hypertension. The first step is brain imaging with contrast. Ideally, you want an MRI of the brain with contrast and an MRV of the head. If you cannot get it right away, a head CT will be enough to rule out intracranial hypertension, to rule out an intracranial process suggesting intracranial intracranial hypertension, but you want the CT to be without and with contrast. And if you're going to do a CT, you want to do a CT venogram at the same time, because a plain head CT without contrast will never be enough. And then you may have an answer on your brain imaging, in which case you transfer the patient to neurosurgery, or the brain imaging is either normal, rules out an intracranial process, but will show signs of intracranial hypertension, in which case the next step is a lumbar puncture. The lumbar puncture includes measure of the CSF opening pressure and CSF content. If it's abnormal, if the CSF contents are abnormal, it's called a meningitis. Or keep in mind, some patients with a spinal cord tumor will have very high CSF protein in the spinal fluid. And this may be the first sign with papilledema and intracranial hypertension of a spinal cord tumor. On the other hand, if the CSF is normal, but the CSF opening pressure is also normal, this is when you have to ask yourself, did I make a mistake, and did this patient not have true disc edema? Could it be pseudo-disc edema? Could it be optic nerve head drusen? Could it be a congenitally anomalous optic nerve? Or if you know for sure it is disc edema, then is it another cause of disc edema, such as optic neuritis? Or did the people who performed the lumbar puncture not measure the pressure well, which can happen? But in many situations, the CSF contents are normal, the pressure is elevated, and you make the diagnosis of intracranial hypertension. And indeed, as you know, we have diagnostic criteria for idiopathic intracranial hypertension. These patients have isolated increased ICP. They complain of headache. They often complain of diplopia. They all have papilledema, which is a major sign of intracranial hypertension. The brain imaging rules out an intracranial process and eliminates venous sinus thrombosis. The CSF contents are normal and the CSF opening pressure is elevated. And the criteria highlight 25 centimeter of water cutoff for adults and 28 centimeter in kids. However, I want to highlight one thing on the lumbar puncture. Remember that the measurement of the pressure is not always reliable. It's difficult to measure the CSF opening pressure when doing an LP. The patient needs to be laying down. If the patient is sitting up, the pressure will not be interpretable because of gravity. And then the ICP fluctuates. You need to compare it to the blood pressure, for example. You know, the WHO says blood pressure greater than 140 millimeter for the systolic, over 90 for the diastolic is the definition of hypertension. But some patients have 150 over 95 as their normal blood pressure, and some patients who are 130 over 75 have high blood pressure. It is not a cutoff, is it? It's a continuous curve, which is, and the cutoff is based on where the vast majority of patients stand. So use your common sense. If you have a patient who has papilledema on examination, and the pressure is 30, you make a diagnosis of IIH, it makes sense. If a patient has no papilledema and the pressure is 30 on an LP performed for whatever reason or for just isolated headache or migraine, it's not IIH. No papilledema, no IIH. On the other hand, if the patient has papilledema but the pressure is only 20, of course the patient has IIH. The patient has IIH because the patient has papilledema. That does not lie. It has to come from somewhere. Maybe the pressure was not measured well. Maybe a pressure of 20 is elevated for this patient. So just be careful when you interpret a CSF opening pressure. Do not interpret it in isolation. Keep in mind that you have some time to break the rule and not necessarily use the definition of 25 centimeter of water in adults and 28 centimeter of water in children. So IIH, as you know, really likes people who are overweight. Women more than men, post-puberty more than pre-puberty. The vast majority of patients are obese or overweight. The risk of IIH increases with the BMI, and the risk of IIH-induced vision loss also increases with the BMI. And this is important to keep in mind because, as you know, the incidence of IIH is increasing. It's increasing everywhere around the world in parallel with the epidemic of obesity. And I'm showing you here the increasing graphs over the past, over the course of 6 years between 2016 and 2022 in the US. This is important because in the US, just as an example, and I know you are not spared, it was predicted that by 2030, at least 50% of the general population would be obese. Does this mean that we are going to need to consider IIH in 50% of the population when they complain of headache? I really do hope not. Otherwise, we are going to have a lot of work. The good news about IIH is that most often it's relatively benign, like the first patient I showed you. However, it's a chronic disease, and many patients complain of chronic headaches, depression, reduced quality of life. You know that the main sign of poor outcome and poor prognosis in IIH is vision loss. Almost all patients have abnormal visual fields at presentation, and about 1 out of 4 patients will keep permanent vision loss eventually. It usually is a monophasic disease. It comes, it goes, especially when the patient is able to lose some weight. However, some patients will fluctuate or will have recurrence, especially when they regain the weight. The evaluation of IIH is really based on evaluating the headache and what can you do to treat the headache, the diplopia, and the visual function. And to evaluate the visual function, you need visual field testing. You cannot just wiggle your fingers and consider that confrontation visual field is enough. You need to collaborate with colleagues from ophthalmology or neuro-ophthalmology if you have access to some, but you don't need necessarily a neuro-ophthalmologist. You need a neurologist and an ophthalmologist who will have access to a visual field machine, which is pretty much 100% of ophthalmology clinics. And you want automated perimetry. I am showing you here a Humphrey visual field. Everything that's light gray is normal. This patient has large blind spot in the setting of severe bilateral papilledema. The reason why you want the visual fields is because if then the patient develops more constriction of the visual field, it means that the papilledema is worsening, that the optic nerves are not tolerating the swelling, and that you need to intervene more aggressively and sometimes emergently, because you want to avoid what happened to the previous patient, patient number 2, which is these terribly constricted visual fields. How do you predict the visual outcome? Well, it's very hard. There are a number of studies that have looked at baseline characteristics of patients and results of the initial visual evaluation to try to help you predict the visual outcome. And I always have this checklist in my mind when I see a patient with a diagnosis of IIH. Patients of Black race have a worse visual outcome. I told you female are more often affected, but male can too, and their visual outcome is not as good. Severe obesity, anemia, especially iron deficiency anemia, which is very common in young women, sleep apnea syndrome, concomitant high blood pressure. And it's important to measure the blood pressure in any patient who has bilateral optic disc edema, because patients can have a combination of very severe hypertensive retinopathy and papilledema from intracranial hypertension, in which case you need to treat both, and you know that the visual outcome will not be as good. And then when the patient already has vision loss at presentation, such as patient 2, with visual field defects or a relative afferent pupillary defect telling you that one of the optic nerve is really not tolerating the swelling at all, you need to intervene rapidly. And then the presentation of patient 2 is always very concerning, very rapid onset. We usually say within 2 to 3 weeks, and this is the definition of what we call fulminant IIH. how to prevent vision loss by predicting the prognosis so that you can decide very quickly of the most appropriate treatment. And in 2025, the treatment of IIH is well codified. The diagnostic lumbar puncture is very important. And I really insist on the fact that every patient with bilateral optic disc swelling suggesting papilledema must have an LP. You need to do the LP because the LP is going to confirm the diagnosis of IIH and is going to help you rule out other causes of isolated intracranial hypertension. So, for example, any meningeal process, syphilis, sarcoidosis, an infection in the CSF, carcinomatous meningitis will mimic IIH by presenting with headaches and papilledema. So you need the LP. Additionally, the LP, as you can see on this graph here, will very quickly decrease the intracranial pressure. And if you start acetazolamide right away, the acetazolamide will work best at preventing the intracranial pressure from climbing up. The LP very often resets the CSF pressure threshold. If you don't do an LP and you just give acetazolamide, the intracranial pressure is going to decrease moderately, very slowly, and it's going to take weeks and weeks and weeks before you have a clinical effect. So do an LP, give acetazolamide, and you may actually sometimes cure the patient by resetting the threshold. Acetazolamide is the treatment of choice, at least 1 gram. I go sometimes up to 3 grams. Most of my patients are on 1,500, 2,000 milligrams. The IIH-TT prescribed as high as 4 grams a day, which is very high and very poorly tolerated. The acetazolamide is associated with lots of side effects. You warn the patient and you tell the patient to just take it anyway, because it's also going to help them with weight loss. And it has a good effect on the intracranial hypertension. The other diuretics do not have an effect important enough to treat IIH. Topiramate can also be helpful, especially because it can help with a headache and it can help patients lose weight, particularly useful for patients who mostly have headache and very little papilledema. And it's important to note that acetazolamide and topiramate are not approved, for example, by the FDA in the US. It's not approved by the European Medical Agency. I don't know what the situation is in Peru, but I doubt it is approved by the official agencies either. Weight loss is the most important part of the treatment of IIH. Diet always helps, but it's very hard. Surgery for weight loss certainly can help. And then, you know, the newest drugs that help with obesity, the GLP-1 receptor agonist certainly can help in this situation. You want to treat the risk factors, the anemia, the obstructive sleep apnea, concomitant high blood pressure, stop any medication that may be associated with IIH. You want to treat the headaches independently of treatment of the intracranial hypertension, because more than 50% of patients with IIH will end up developing chronic headaches that have nothing to do with the intracranial pressure. So, for example, it is very common to have a patient who will be diagnosed with papilledema because the patient had headaches. The diagnosis of IIH is made, the patient is treated with acetazolamide is weight loss, the papilledema resolves, telling you that the intracranial pressure has become normal, but the headaches stay. And that tells you that this patient has a multifactorial headache. The intracranial hypertension triggered the headache initially, but then they became chronic, combination of analgesic abuse headache, chronic headache, migraine headache worsening, chronic tension headache worsening. And this is why we always send our patients to our neurology colleagues so that patients can not only receive the treatment of the intracranial hypertension with acetazolamide, for example, but also be started on medical treatment for chronic headache. And I always want to highlight that no, we should not treat these patients with steroids. It can make them feel better for a short period of time, but they induce weight gain, as you know, and it's very counterintuitive to want to treat IIH with steroids. And then you predict the prognosis, you follow the visual fields and the fundus, because you want to see the papilledema resolve and you want to see the visual fields remain either normal or get better. And if it's not the case, you should consider repeating the lumbar puncture. Some patients will need 2 lumbar puncture or 3 lumbar puncture. If they need more, it means you need surgery. It is really difficult for these patients who are usually overweight to undergo multiple lumbar puncture, and I do not believe that serial lumbar puncture is the appropriate treatment for this disease. In the United States, oculoplastic surgeons can perform optic nerve sheath fenestration, which is a nice way to temporize the problem when patients have very severe papilledema and vision loss. However, in most situations, CSF shunting procedures are preferred because they treat everything at once, correct? They will decrease the pressure and therefore improve the headache, make the diplopia go away, and help the papilledema go away. And nowadays, ventriculoperitoneal shunt are usually preferred to lumboperitoneal shunt, but the neurosurgeons decide what they want. As you know, endovascular stenting of the transverse sinus stenosis is also a possibility, and we will talk again about this. And then, of course, bariatric surgery that will help the patient lose weight very quickly is something that needs to be seriously considered. It is very important to highlight the fact that this works very simply by mechanically decreasing the intracranial pressure. There is no clinical trial that has compared optic nerve sheath fenestration, CSF shunting procedure, or endovascular stenting. And therefore, what you decide to do is really based on what you have available in your respective country, at your respective institution, or wherever you practice. And this is why, depending on who gives a talk, some people will only talk about stent, some people will mostly talk about optic nerve sheath fenestration, and everybody will tell you, we can do a shunt, but we don't like them. Yes, they have complication, but the truth is you don't need these procedures very often, and the risk of complication is always worth it when you perform the procedures for the right reason, which is vision loss. We tend to not recommend these procedures for chronic headaches because, as I said before, most chronic headaches are not related to ongoing intracranial hypertension, and therefore, even if you place a shunt in, even if you place a stent in, very often the headache will persist. So I personally reserve these procedures for patients with severe papilledema whose visual function is at risk. A word on venous stenting. As you know, all patients with chronic intracranial hypertension have stenosis of the distal part of the transverse venous sinuses, which is very soft. And it's a combination of what they call intrinsic stenosis from, for example, large arachnoid granulation or being born with a congenitally narrow venous sinus, and external pressure on the transverse venous sinus from the intracranial hypertension. As you know, the CSF is passively absorbed in the venous sinuses, and when there is a transverse venous sinus stenosis, the venous pressure increases, and when the venous pressure increases, you have what we call venous hypertension, and the venous hypertension will decrease the CSF absorption, which will contribute to increased intracranial pressure. So we have this vicious cycle here, which you can disrupt by placing a stent, which will immediately result in decreased venous pressure, and therefore increased venous absorption, and therefore decreased ICP. So it works. It works well on patients with papilledema. It doesn't work as well on patients on the headaches or on patients with isolated headaches. But the vast majority of patients have those stenosis and do not need a stent because they will do very well with only medical treatment. Not every country, not every place has access to endovascular venous stenting. When I was in Peru a year ago, I was told that it was not really available in many places in Peru. It's okay. You can use the shunt, which works very well whenever you have the need for a more aggressive treatment. But you need to understand the place of stenting because it is rapidly expanding, and many people use it each time they see a transverse venous sinus that's stenosed on MRV. And I want to highlight that it's really not necessary. I always tell people, even in 2025, venous stenting is not for everyone. Do not treat the MRI, treat the patient. Most cases are benign, and the venous stenosis may even improve or resolve after the LP or other treatments of raised ICP. But yes, it can be helpful in patients who have bilateral stenosis resistant to medical treatments. So the reason for my title about the spectrum of IIH expanding, it's because in neuro-ophthalmology, we always talk about these two, correct? Case number one, the classic IIH, mild, that does well with simple medical treatment. Case number two, the rare fulminant IIH that does not well with medical treatment, needs very aggressive intervention. But IIH is way more than this. And this is illustrated by the 35-year-old overweight woman who has a brain MRI for whatever reason, for tingling. And the radiologist says normal MRI, with the exception of an expanded and empty cellar, which you can see here, which can be seen in idiopathic intracranial hypertension. So this is a very common reason for ophthalmologic and neuro-ophthalmic consultation. Of course, these people are overweight, but everybody is overweight nowadays. And there's a very good chance this person also has episodic headaches or chronic headache, because at least 1 out of 4 women has headaches. And so does it mean that each time you have an unsanitary found empty cellar and some headaches, you need to go further and do a spinal tap? The answer is absolutely not. What you need to do is either neuro-ophthalmology or ophthalmology consultation to rule out papilledema. Because if there is no papilledema, it's not IIH. And as you can see here, this patient did not have papilledema, but she had interviewed Dr. Google, and she came to us with 3 questions. Does this patient need a lumbar puncture? There is no papilledema. My answer is no. Does this patient has IIH? No papilledema, no IIH. Should this patient be treated with acetazolamide? And the answer is no. Acetazolamide is a great treatment of intracranial hypertension when there is papilledema. And the clinical trial IIHTT clearly showed that the acetazolamide was better than placebo in addition to weight loss and a lumbar puncture to help papilledema go away faster. But acetazolamide did not help with the headaches. So there is no reason to treat a patient who has an empty cellar, some headaches, with acetazolamide, assuming the headaches are from raised intracranial hypertension. So my answer is no, no, no. Send the patient to a neurologist if the patient has headaches for medical management of chronic headache, and do not think this patient may have IIH. However, it's not that simple, as you know. And for those of you who are headache specialists, you know that some patients actually do have IIH and never develop papilledema. Not everybody is built the same way. We don't really know why it happens. So it does exist. And we call it IIH because we have not come up with a better word. But remember that for the diagnostic criteria of IIH, you need papilledema. So there are patients who have chronic headache from elevated intracranial pressure who will respond to treatment of the intracranial pressure, but these patients are very rare. It does exist, but it's very rare. Isolated empty cellar with or without headache is very common. It's about 20% of the general population. And why do I highlight that? It's because, as I said earlier, the management and the follow-up of the patient with IIH is really based on the predicted risk of vision loss. And as you know, vision loss only happens when you have papilledema. If you have no papilledema and you have normal optic nerve, you cannot lose vision. You may see blurry because you have a bad headache, but you are not at risk of optic nerve damage from papilledema if you don't have papilledema. And since we decide that a patient will need aggressive treatment, will need a repeat LP, will need surgery for intracranial hypertension, mostly based on the risk of vision loss, when you have no papilledema, you should not be aggressive and you should focus on medical management. So now, as you know, some patients have chronic tinnitus from chronic venous sinus stenosis. And in ENT, our colleagues from the ENT specialty call this the ENT IIH. Is it IIH? Probably no, they don't have papilledema, they have no risk of vision loss, but these patients probably had intracranial hypertension at some point in their life. Same for those who have skull-based changes with encephalocele, which sometimes may evolve to give what we call a spontaneous CSF leak. So all this is on the spectrum of IIH, but these patients do not have the IIH we neuro-ophthalmologists treat. And because they have no papilledema, they have no risk of vision loss, and therefore the management is very different. What they have in common, though, is probably the overweight and the need to lose weight. And it's very likely that by preventing obesity and figuring out the best ways to help this patient lose weight, we are going to solve many of these issues. So because of this, I really believe that the future of IIH, our IIH with papilledema, and what I call IIH spectrum disorders, is the development of IIH comprehensive centers with access to multidisciplinary care. Because these patients, they need a neuro-ophthalmologist, ideally if you have one, but they need an ophthalmologist, they need neurology for the management of headache. They often need ENT if they have CSF leak, if they have tinnitus. They often need neurosurgery for the lumbar drain, for the CSF shunting procedure. Endovascular neuroradiology if you're considering stenting. They need nutritional help because these people cannot lose weight and they need a bariatric center. And the best is to at once, at the first visit, address the risk of vision loss, the management of headache. How are you going to lose weight? How can I make your quality of life better? Which specialized treatment, whether drugs or procedures, do you need right away? And how am I going to help you with the long-term outcome by preventing weight gain? So in summary, what you really need to remember about IIH. The diagnosis is really easy nowadays, thanks to the criteria and to the easily available brain imaging. But the diagnosis is also often made in excess in patients who have chronic headaches, in patients who do not have papilledema, in patients who have borderline intracranial hypertension. Not every obese young woman has IIH. Migraine remains much more common. Radiologic abnormalities are present in many normal people. Do not treat the MRI. If you are consulted because a patient was found to have an empty cellar, an encephalocele, venous sinus stenosis, dilated optic nerve sheath, do not make necessarily a diagnosis of IIH. Look at the back of the eye. If there is papilledema, it's probably going to be IIH. If there is no papilledema, it's not IIH. Don't panic. Do not treat the MRI. Visual function is absolutely essential. You collaborate with your best friend ophthalmologist to follow the visual fields. If you don't have a neuro-ophthalmologist, it's okay as long as you have an ophthalmologist. And we're talking about real visual fields, not wiggling your fingers. Automated perimetry is what's needed. Predict the prognosis and have a checklist in your head. Is it a male? If the patient of black race, is this patient very obese? Is there anemia? Look for iron deficiency anemia and treat it in every young woman. Is there obstructive sleep apnea? Treat it. What is the blood pressure? Treat it. Are there medications that could precipitate IIH? Make them go away. Treat the chronic headache, as neurologists know to treat chronic headache, not just with acetazolamide. Treat the patient as a whole. This patient may do well because the papilledema will go away, because eventually they'll be okay. But the truth is, most of these patients really do not feel well, and their quality of life is terribly affected. These are young people who are trying to go to school at the same time, trying to work at the same time. They are overweight. It's not their fault. And you send them home asking them to lose weight, and they are just miserable. Weight loss, we say at least 10 to 20% of their original body weight. Do not try to make these people become skinny. Not everybody is made the same way. But there is evidence that if you lose between 10 and 20% ideally of body weight, you can normalize the intracranial pressure. So that's really the treatment for IIH that will help the patient improve and then keep the intracranial hypertension from coming back once you are able to stop the acetazolamide. We keep the patients on acetazolamide until the papilledema is completely resolved. When it's resolved, then we can stop it. But if they have not lost any weight, it may come back up. On the other hand, if they have lost weight, often they are cured. Use procedures wisely. The shunt, the stent, the optic nerve sheath fenestration, yes, they work, but they are usually not needed. If the patient gets better with medical treatment alone, you don't need procedures. And in my mind, wisely means rarely. And multidisciplinary care is really the key to success. If you're a neurologist, have a best friend ophthalmologist, a nutritionist, partner with a headache center and the primary care doctor. If you're an ophthalmologist, you need a neurologist to work with you, ideally a headache neurologist. You need to have access to a nutrition clinic and you need the help of primary care doctors. Thank you very much. I hope you enjoyed, and hopefully my colleagues will be able to answer any questions you may have. Thank you again for asking me to participate in your seminars. Bye-bye.
Grandiosa presentación de la doctora Valerie Biousse. Agradecerle que pese a las dificultades mandó su presentación. Pero hay que también dejar conceptos claros de lo que ha dejado la doctora Valerie Biousse en esta charla, para que la audiencia, hay muchos que están en aprendizaje, muchos son residentes e incluso algunos que están empezando en este rubro. Hay que dejar sus conceptos claros, por acá tengo algunos que lo he fijado. Primer concepto, no sobrediagnosticar hipertensión intracraniana idiopática. Valerie nos recuerda pues que existe una tendencia a diagnosticar en exceso, como lo ha mencionado. Es importante pues respetar los criterios diagnósticos, correlacionar los hallazgos clínicos con la exploración y no asumir hipertensión intracraniana idiopática solo por un hallazgo radiológico o una cefalea. Otro concepto menciona, no se trata la resonancia, sino se trata al paciente. Los hallazgos radiológicos pueden apoyar el diagnóstico, son ayuda diagnóstica, recordemos, exámenes auxiliares, pero no son indicación del tratamiento por sí mismo. Por lo tanto, las decisiones deben basarse en función visual y en los síntomas. Otro tercer concepto, el seguimiento del campo visual es clave en el manejo de la hipertensión intracraniana idiopática. El daño visual puede ser irreversible, por lo que es esencial realizar campos visuales seriados para valorar la progresión o mejoría, más que solo guiarse por una apariencia y papiledema. No basta con hacer seguimiento de papiledema, sino del campo visual que podría estar complicándose el paciente y tomar una decisión. Otro concepto, el tratamiento fundamental, que es la pérdida de peso. Eso es bastante gravitante en este cuadro. Tan importante como la medicación de acetosalamida, e incluso hasta más importante la disminución de peso. Ahora no solo se habla de hasta un 10%, puede hablarse del 10 hasta el 20%. En estos casos, la disminución importante, como mencionó Valerie. ¿Ya? Otro concepto es el manejo multidisciplinario, que mejora la calidad de vida. No basta con un oftalmólogo que puede pedir una ayuda de un neurólogo cuando se trata de una migraña que viene concomitante con este cuadro. A veces comienzan a querer seguir insistiendo, porque la cefalea persiste, pese a que prácticamente se ya menguó lo que es el papiledema. No hay que confundir. Hay que ver también que puede tener una migraña y ya el cuadro está remitiendo todo lo que es la hipertensión intracraniana. Por otro lado, hay muchas personas que erróneamente terminan en cirugía cuando no amerita una cirugía, como lo ha mencionado Valerie. Solamente un porcentaje mínimo va a cirugía. Algunos casos que son refractarios al tratamiento o una hipertensión intracraniana fulminante, en la cual en días, semanas se va la visión, el defecto visual, más no en las incisiosis crónicas, que la mayoría sale con simplemente tratamiento médico. Esos son conceptos importantes. No sé si quieras agregar algo a esto, Alfonso, o si hubiera preguntas en el chat de algunos residentes o algo.
Bueno, no hay preguntas en el chat, pero yo entiendo pues que, bueno, la mayoría de colegas que están prendidos en esta charla, bueno, no han tenido experiencia o muy poca experiencia con hipertensión intracraniana idiopática, ¿no? Yo creo que tienen más en la mente el concepto de repente de papiledema, ¿no? Entonces, y
Mm.
es algo que, digamos, a los alumnos, a los residentes, siempre le tratamos de puntualizar, ¿no? ¿Qué cosa es un papiledema? Y que lo diferencien bien de un edema de papila, ¿no? Porque hay mucha uso erróneo de la terminología y que el primer punto es aclarar eso, ¿no? Que el papiledema, un papiledema es causado por hipertensión intracraniana. No todos los papiledemas son hipertensión intracraniana específica, o sea, idiopática. Entonces hay que descartar las causas de papiledema para luego poder entender qué cosa es una hipertensión intracraniana idiopática. Creo que hay una mano levantada, Justin.
A ver si se le puede dar, o la pregunta lo hace al chat, o cómo es en este caso.
Ya está abierto
Hola,
su
buenas
micrófono.
noches.
Ya, sí, diga.
Hola, buenas noches.
Buenas noches.
Eh, el chat está deshabilitado, por eso no puedo escribir.
Ah, ok, qué raro.
Em, sí, y quería felicitar a la doctora. Excelente presentación. Yo quería preguntar si en un paciente con papiledema severo, importante, de más o menos de 19 años de edad, el abordaje es el mismo, teniendo en cuenta que este paciente es delgado.
Si es un paciente que cumple con todos los criterios de la hipertensión intracraniana idiopática, estamos hablando de una persona joven, obesa, con papiledema, con cefalea, quizás hasta tignitos pulsátiles, y en esa sospecha diagnóstica uno confirma con la presión de apertura y está por encima de los 250, eso es diagnóstico ya redondo. Confirmando que es un verdadero papiledema y descartando por neuroimágenes que no tenga nada que explique la hipertensión intracraneana. Solo los signos indirectos como mostraron, ¿no? Como aplanamiento del polo posterior, como la silla turca vacía, y como estenosis de los venos transversos, etcétera, etcétera. Son los tiene que hacer unidad clínica, redondear todo el diagnóstico, porque es por exclusión para que digas idiopático. Aló, sí,
Sí,
no
no hay
sé.
diferenciación, que yo sepa, no hay diferenciación en el tratamiento por la edad. Si sea un chico o una chica de 19 años o mayor, eh, tiene que reunir los criterios y lo primero que se tendría que hacer es hacer una neuroimagen para descartar la presencia de un proceso expansivo o una estenosis de los senos venosos, ¿no? Que no haya un secundarismo. Lo segundo sería hacer un estudio de líquido cefalorraquídeo y medir su presión para poder completar los criterios diagnósticos, ¿no? Y obviamente que tenga un papiledema en el fondo de ojo.
Así es. Casualmente contándole un poco la experiencia, hace poco hemos visto en el Instituto Neurológico, en el Mogrovejo, una paciente en la cual tenía diferentes signos radiológicos. Cumplía, entre comillas, una hipertensión intracraniana idiopática, pero resulta que después se le encontró un líquido cefalorraquídeo no tan normal que digamos. Tenía el cloro bajo. Entonces, uno relacionaron a la tuberculosis, pero finalmente hablando con uno de los médicos de neuroinmunología, resulta que encontraron después cisticercos a nivel cervical. Eso no es idiopático y tampoco era tuberculosis, terminó siendo esto. O sea, es de exclusión para que uno diga hipertensión intracraniana idiopática. Tenerlo presente siempre es.
Hay una pregunta en el chat,
Ujú.
dice si se tiene una resonancia que muestra silla turca vacía, sin papiledema, y la
Ya.
presión de apertura es 20 o 25, ¿deberíamos tratar?
No, bien claro lo mencionó Valerie en su presentación.
Ujú.
Si no hay papiledema, no es hipertensión intracraniana idiopática. Si yo tengo 30 de presión centímetros de agua y no hay papiledema, tampoco es hipertensión intracraniana idiopática. Esos conceptos lo dejó claro Valeria en la presentación de hoy. ¿Ya? Otra cosa es la técnica, cómo le hacen la punción lumbar, la presión de apertura. Es importantísimo. Sea de cúbito lateral derecho o izquierdo, no interesa, pero es que el paciente esté relajado, que no esté ansioso, ni conversando, que no altere la presión, que esté una semiflexión, pero no tan hiperflexión, porque altera la presión de apertura. Tener concepto bien claro acerca de ello.
Ok, hay otra pregunta, dice, ¿cuánto tiempo se puede usar acetazolamida en su experiencia? ¿Cuánto tiempo es tolerable?
Ya, acerca de la acetosalamida, uno, como le digo, maneja el papiledema. Uno puede ir escalando semanalmente, por ejemplo, 250 miligramos que vienen las tabletas cada 12 horas. Luego la segunda semana puede ir cada 8 horas. Y luego la tercera semana van aumentando, que son 500 cada 12. Y así se puede ir escalando de a pocos, en semanas. Una vez que domina, disminuye el papiledema. Y se ve, por ejemplo, que el papiledema comienza a reducirse. Pero en los exámenes de hallazgo, como dijo también Valerie, no solamente seguir el papiledema, seguir también los campos visuales. Si vemos que el campo visuales está yendo bien, no se compromete más, estamos por buen camino. Y luego, una vez dominado el papiledema, se va buscando una dosis que mantenga y lo más importante que es el peso. El peso es mandatorio. Si uno reduce el peso y más adelante ese paciente vuelve a ganar peso, está en contra también de esto. Hay que jugar con todo eso. Ahí dice en la
Bueno,
hipertensión
hay
de
otra.
canal fulminante, cuando se recomienda una penetración de nervio óptico y cuando se recomienda una derivativa. Ya. En el caso de hipertensión de canal fulminante, sí o sí, cirugía. Porque esto usted está hablando de días o semanas que se lleva toda la visión, te puede dejar ciego. Usualmente, la mejor técnica que se domine en el medio. Si estamos perdiendo visión, ahí podría ser fenestración. Pero alguien lo tiene que saber hacer. En el medio un poco que carecemos de esto. Ahora, si hay bastante predominantemente cefalea, se podría decir el shunt, lumbar shunt. Depende mucho de muchos factores, pero depende de la habilidad de los cirujanos con la que contemos aquí en Perú, ¿no? No estamos en Estados Unidos. Allá lo escogen, problema visual, mayormente fenestración. Problema más cefalea predominante, lumbar shunt. Pero no, como dijo Valerie, el porcentaje es mínimo, solo en estos casos, fulminante y los refractarios al tratamiento. El resto, tratamiento médico.
Hay otra pregunta que dice si es que es muy sensible la resonancia magnética para visualizar el papiledema o si es mejor verlo por oftalmoscopía. Bueno, obviamente verlo por oftalmoscopía, ¿no? Hay algunas formas complementarias que se pueden utilizar como, por ejemplo, el OCT. El OCT sí se puede utilizar como una forma de medición del edema de las fibras y la disposición también de las fibras hacia arriba cuando se quiere descartar, por ejemplo, pseudopapiledema, ¿no? Pero resonancia magnética solamente nos ayuda con los signos indirectos, que son la silla turca vacía y el aplanamiento, que puede ser, sí, un punto a favor de hipertensión cuando hay un aplanamiento del polo posterior de los globos oculares.
Así es, así es.
Hay otra pregunta, la rinorraquia sin fístula de líquido cefalorraquídeo en paciente con hipertensión intracraniana y estenosis de senos venosos, ¿se asume como hipertensión intracraniana?
Si no hay papiledema, no es hipertensión intracraniana. No nos guiemos solamente por imágenes. Y por lo otro, antes que me olvide, la silla turca vacía, si yo la encuentro aislado y no tiene relación con papiledema, tampoco es. Se puede encontrar en personas normales hasta cerca del 20%. Un
Claro, este
criterio.
problema de la rinorraquia es un signo, bueno, de otorrino, ¿no? Pero puede ser también causado por varias cosas, ¿no? Habría que ver la etiología de la rinorraquia, pero no necesariamente tiene que ser directamente relacionada con una hipertensión intracraneal.
Así es. ¿Hay más preguntas? Creo ya no.
No, no encuentro más. Ah, ya, aquí hay una pregunta que no se contestó.
Ya.
Gracias por compartir la exposición. Mi consulta es sobre el uso de topiramato o acetazolamida. ¿Cuál es más tolerado?
Acetazolamida. Bueno, sobre todo en algunos, aprobado la acetazolamida. Creo que no está aprobado el topiramato, como lo menciona Valerie, ¿no? En la FDA, pero sí en el medio europeo. Sobre todo se
Sí, bueno,
usaría topiramato cuando no tolera bien de repente a lo que es la acetosalamida o algo por el estilo, o está asociado de repente a una migraña concomitante con el cuadro de hipertensión arterial idiopática. Podría probarse por ese lado, pero son mecanismos casi similares.
sí, bueno, el tratamiento aprobado es acetazolamida, ¿no? Y se hizo un estudio clínico para su uso, porque hasta hace pocos años existía el uso de acetazolamida, pero no había el clinical trial. Y después que
Ujú.
se hizo el clinical trial, ya sí se aprobó por la FDA el uso de acetazolamida, ¿no? Que es lo que está más aprobado. Sí.
Perfecto. Creo que ya no hay más preguntas, ¿verdad?
Mm,
Ya.
sí, esas son
Bueno,
todas.
si no hay más preguntas, agradecerles y siempre recordarles que cada tercer martes de cada mes tenemos la sesión de neurooftalmología de la Sociedad Peruana de Oftalmología. Al siguiente mes tenemos otro invitado de Estados Unidos. Es nada menos que Kathleen Whittaker desde Estados Unidos, del Moran Eye Center. ¿Ok? Agradecerle, Alfonso, agradecerle a todo el público que nos acompañó esta noche. Muchas gracias a todos. Hasta la siguiente oportunidad de la sesión de neurooftalmología. Muchas gracias. Hasta luego. Gracias, Alfonso. Gracias.
Saludos a los colegas que nos acompañan del extranjero. Saludos,
Ah,
amigos.
sí. Saludos a todos a los de Latam, toda Latinoamérica. Saludos a
Y
todos. Gracias por
saludos,
su presencia.
saludos, amigos peruanos. Gracias.
Gracias. Hasta luego.